Ahmed Sami for another upper limb viva. Are you ready, Ahmed?
Yes. Yeah.
Okay, so you've got this 46-year-old carpenter presenting to A&E. He's right-handed and a smoker. He sustained this injury just hours ago after falling on his outstretched hands. What are your thoughts on how would you manage?
So I can see in the radiograph, it's a lateral radiograph of the elbow joint, showing at least a posterior elbow dislocation, a fracture dislocation. I won't take any other views because it's clearly dislocated. I can see that the radial head is broken, as well as the coronoid. This fits the diagnosis of a terrible triad injury, and I'm thinking that either the lateral collateral only or the lateral collateral and the medial collateral of the elbow ligaments are gone, and that's the reason the elbow dislocated. Assuming this is an isolated injury and the ATLS protocol is being applied, I'll try as soon as possible to reduce that elbow back in place. If the local hospital guidelines would allow me, I'll try to do that under sedation in the A&E. But before that, I'll examine the patient for any neurovascular deficit. I'll also want to examine his distal radial ulnar joint for any tenderness or instability. Then after obtaining the verbal consent, I'll proceed and reduce the fracture dislocation. I'll do a traction and flexion of the elbow. I'll have an image intensifier to confirm the reduction before I apply a back slab, above elbow back slab in flexed pronated position, because this is the stable elbow position.
Okay. You've done all that, and he's neurovascularly intact, and as we mentioned, it's an isolated injury. What step do you want after that?
This is a type of injury which will need the definitive fixation unless there's an obvious contraindication to that for better outcome. It's a complex injury which needs ideally to be done by an elbow surgeon. I will, to help prepare for the surgery, I'll need a CT scan to be able to assess the configuration of the radial head fracture, as well as the configuration of the coronoid fracture.
Yes.
I need more images to be able to have a look at the radial head. The radial head is classified by the Mason classification, and a comminuted radial head will need replacement as opposed to fixation, whereas a Mason 1 or 2 might need only fixation. Depending on the size of the coronoid fragment, I might need to fix it as well. If there's more than 50% involvement, this again affects the elbow stability and will need to be fixed surgically. And also I have to repair or reconstruct the lateral collateral ligament or the medial collateral ligament.
Okay, so the CT, maybe we don't have all the cuts, but basically what it shows is that the radial head is pretty much comminuted. The coronoid is, well, borderline, maybe 40% or so. So how you're in theater now. What position are you going to place him in?
So I know there are controversies about the incisions and approaches used, but by my preferred incision, if I'm the operating surgeon, my preferred incision would be the Cocker approach. For that, I'll place the patient on supine with the arm board and a flexed elbow. My landmarks, I'll do a tourniquet. My landmarks will be the lateral epicondyle and the radial head. I'll draw a line from the lateral epicondyle, radial head extending around 2.5 centimeters distally. And size the skin, the superficial fascia. It's an internervous, it's a true internervous approach. Has a true internervous plane between the encomius, which is supplied by the radial nerve, and the extensor carpi ulnaris, which is supplied by the posterior interosseous nerve. Provided that I'm fixing all three elements of the injury, I'll start with the coronoid fracture first, as I will have access because of the fractured radial head. After fixing that with a screw and button, I'll do a replacement of the radial head because it looks comminuted on the CT scan, and then I'll proceed to repair the lateral collateral ligament, and I'll reassess the stability afterwards. to make sure that the elbow is stable through a flexion extension as well as supination pronation range.
Okay, that's very good. Thank you. Thank you very much.
Thank you.
Okay, so what do you think?
I think it went relatively well. I might have forgot some stuff, but I quickly caught up and got back to it. I had time to talk about the management and the approach. So this is for me in my real exam or my viva practice was reassuring that at least I had enough time to get to that point. So I think more or less reasonably well.
Yes, I think you did very well, and it's a pretty straightforward viva, a very common one you should be ready and prepared for. Maybe the direction the viva could go into, instead of talking about the approach, it could go into the direction of the elbow ligaments. And I think in some instances we've heard of candidates being asked to draw the elbow ligaments or to demonstrate where they're inserted, points of insertion of the different ligaments. Okay, thank you.
Thank you.